Okay, so we are all good to go, and welcome to our third Northwest ATTC webinar of 2018. My name is Bia Carlini. I'm a senior research scientist here at UW, and the webinar series coordinator, among other roles at Northwest ATTC. That being said, it's my pleasure to introduce our speaker today, Tom Fuchs, who will share with us an overview of the many projects in development in the Washington state funded by SAMHSA and known as STRs, or State Targeted Response to the Opioid Crisis Grants. Thomas is the Substance Use Disorder Administrator of Washington State Department of Social and Human Services, or DSHS, under the Division of Behavior, Health and Recovery. He's not only involved on this SAMHSA grant, but also in other important projects at the DBHR, such as naloxone delivery education, development of secure detox facilities for individuals on commitment, and also works with DBHR staff to assess and encourage treatment centers to develop capacity to provide dual diagnosis treatment. It's my pleasure to pass then to Tom his slide. It takes a few minutes for things to connect. We are not in the same place, but welcome, Tom, and thank you so much.
Well, thank you very much. I am always a little bit daunted by these sorts of presentations, and with all of the potential glitches, I'm glad I'm here and speaking with all of you. So we're going to move right to the, I'm trying to figure out how to control this still. I'm struggling with a little bit.
There's a slight lag, but you have control of the screen now. You should be able to.
Okay, there we go. So today I'm going to talk about the State Targeted Response, or STAR grant. And this is really all about the federal funding that came through to help states address the issue of the opiate crisis. And for, just so I don't have to say State Targeted Response every time, we just refer to it as STAR, or the WA-STAR grant. Really what we're trying to do today is to talk about really what are the learning outcomes. We're really going to talk about what the grant is, all about the 18 different projects that STAR covers, both in prevention and treatment, and then really the status of the various projects and where they're implemented in the state. And this was a grant that I was incredibly involved with. It came out on December 13th. Actually, it came to us about December 17th, 2016, and it was due by February 17th, 2017. So I really don't remember much of my holiday that time. It was a pretty significant grant, and we spent hundreds of hours on developing it. So this is part of the 21st Century Grant signed in by President Obama as part of that 21st Century Cures Grant. It really talks about promoting research for drug and serious illnesses. It accelerates drug and medical device development. And then really part of it was addressing the opioid abuse crisis and trying to improve the delivery of services. Each state was allocated based on need. There was $485 million in the grant to help states and territories. So it was quite a big influx of funding into the program, and it was a well-needed and well-deserved response. So this is sort of the show me the money. Every state was got different amounts based on their need. Washington received $11.79 million. Within that, there were certain components which we had to adhere to. One was that we couldn't spend more than 5% on staffing or administrative. So that ended up to be almost $600,000. And then we could spend 20% on primary and secondary prevention. So that was about 2.1 million. And then treatment expansion was just over 9 million. So one of the things you do want to notice is that there really was no money for data and data elements, and that continues to sort of affect how we implement the grant and how we're proving its effectiveness. So the grant really required all of these different things. It required a needs assessment and a comprehensive state strategic plan. And I'm really happy to say that Washington State was one of the few states that really had a comprehensive strategic state plan already developed. And the needs assessment was really worked on almost exclusively by another department, research and data analysis at the DSHS. So they really provided invaluable information for us in order to get this grant off the ground. And we also had to implement, enhance, and evaluate primary and secondary prevention using evidence-based methods. So it wasn't just about providing some sort of prevention programs. They really had to be based on evidence. The fourth one is implement and expand clinically, access to clinically for opiate use disorder. So really it was focused on mostly medication-assisted treatment. It was really, it was a major focus of this grant. They wanted us to provide assistance to patients with treatment costs. In some states, treatment isn't covered quite as well. Washington being a fully expanded or wonderfully expanded Medicaid state, we have very few uninsured people, but people with bronze plans or different kinds of plans, they wanted to make sure that they had access to good treatment. We were required to provide treatment and transition to patients reentering from criminal justice settings. And then the last one is that we wanted to support and provision for peer and recovery supports. And that's an interesting component because right now, peer recovery for substance use disorder is not part of our state plan. So it was a major lift for us. So that was all required by the grant. We had to write those elements into it. So the Washington Opioid State Targeted Response, or the STAR grant, is linked. All 18 projects are linked to the opioid work plan. In that opioid work plan, you can just Google Washington State Interagency Opioid Work Plan, and it'll show you that there's all sorts of goals and strategies. But those goals are really, right, as of the writing, were just 4 main goals. The first one being prevent opiate misuse and abuse. Second one is link individuals to treatment. The third one is intervene in opioid overdose to prevent death. And the last one was using data and information to detect opiate misuse and abuse. So one of the really nice parts about this grant was that because we had a state strategic plan, all of it really provided the skeleton or the framework for the 18 plans. So in the writing of this, you know, as a grant writer, first you sort of think about how you can do this in a dynamic and interesting way to connect all the different plans and ideas into one narrative. And after struggling about a week on that idea, we simply decided to number the grants. And so we have 8 prevention grants, 8 prevention projects and 10 treatment projects. And that actually has proven to be a pretty useful way. So this is just an overview of the 8 prevention projects that we have going. So what I'm going to do is I'm going to run through each of the prevention projects and then sort of give you a status of where we're at this point. And I've also included the dollar amount that we're spending on this because oftentimes people want to know where the money went. So this gives you an idea about that. The first one is called the Prescriber Provider Education, and it was $80,000. And that, right below that, connects to goal number 1 of the state strategic plan. And that's promoting the use of best practices among healthcare providers and prescribing opiates for acute and chronic pain. So what we're planning to do was to host a 2-day symposium as part of the Washington State Dental Prescribers and Oral Healthcare Providers. So one of the things that we've recognized are that most often, about 75% of the time, people don't start out abusing heroin. They generally start out utilizing or using or being overprescribed or getting prescription drugs or prescription medications, and then it transitions into abuse and into addiction. So what we've done is we've worked with the Washington State Labor, L&I, Labor and Industry, and we're providing speakers for that event. And at the bottom, you'll see the actual prevention manager who's in charge of this specific project. So the status is that we have speakers, peer-led speakers at these events. Actually, they're coming up very soon, April 19th and April 20th, one on the east side, one on the west side. So one in Spokane and one in Seattle. And we're really excited about working through this. There's also all sorts of guidelines on prescribing opioids. And I know the BRE Collaborative, and I understand the Washington Dental Association just came out with their own guidelines for prescribing opiates in case of oral surgery. So pretty exciting and moving along in this project. The second project is prevention, number 2. It's called University of Washington Telepain, and it connects to goal number 1. And it provides partial funding for the University of Washington weekly telepain program. So this is really an opportunity for folks to get together, doctors, primary care providers, nurses, and really sort of go through and improve their understanding about prescribing practices and how to deal with the more complex individuals who are either using opioids for chronic pain or abusing, and sort of that inner engagement. So as of February 18th, telepain attendance has been 110 logins, 35 MDs, 3 DOs, 3 physician's assistants, and you can just read on. And we've really had all sorts of slide decks on a social worker's approach to chronic pain, how to implement buprenorphine or Suboxone in opiate use disorder, and then sort of the risk of concurrent opioid and benzodiazepines. Actually, the use of opioids and benzodiazepines has been considered a significant problem because people who are utilizing benzodiazepines are certainly at risk, more at risk than if they're just using opioids, and oftentimes are excluded from treatment. So this has really been a pretty good program that University of Washington Telepain Project has been providing. The prevention number 3 is the public education campaign. This is almost $1 million, $868,000, and again, it connects to goal number 1, strategy number 2, which is raising awareness about the adverse effects of opiate use disorder. We know that treating opiate use disorder at the end of if we can prevent opiate use disorder, that's really what most of these prevention projects are about. And so we've really been very active in disseminating public education projects and a message about just recognizing that we can do a lot of things initially to sort of bend the curve with opiate use disorders, and it's been quite a lift. As you can tell, almost $1 million is going into this. And I'm struggling, excuse me, with my moving forward. There we go. Thank you. So the public education, this contract has been executed. We're working with DH out of Spokane. A web-based campaign was launched. I'm hoping all of you have seen it. It's called Starts With One, and it's really been an incredibly vibrant toolkit that's out there to really sort of reach out to both the community, and then secondarily, we have a new lead manager that's conducting outreach to tribes, and we're building a tribal component that is more tribally focused about prevention within tribal communities. So that has really had a more of a late start, but we're catching up very quickly, and we've conducted 2 outreach meetings, and we actually today already I was in a meeting about the final drafts for a lot of the tribal connection pieces. They're actually going to be connected to the Starts With One campaign, but they're going to be more specifically focused at tribal communities. Some pretty exciting stuff. Prevention project number 4 is safe storage and curricula training. This is really all about engaging other state service organizations, and that really we're talking about caregivers, parents, who's reaching out. And so we've talked with other state agencies, and they've submitted proposals up to $5,000 to establish internal training. So let's say we have nursing care, we've got child care, anything that has to do with how do we manage and prevent, we kind of encourage safe storage and training. So it was really all about training to employees at these organizations. So 5 partner agencies have developed action plans. They provide staff provider training around safe storage disposal. And active media is going on, the media campaign about education. And actually our 6th partner actually opted out because they thought it was too much work to go through the contracting process, but are still with us in terms of developing information for working with their employees about safe storage and how to really deal with prevention activities. Prevention project number 5 is workforce enhancements. This is all about, again, connected to goal number 1, preventing opiate misuse and abuse. And it's really all about enhancing the funding for the annual State Prevention Summit and Spring Youth Forum. One of the things we recognize is that we've been dealing a lot with prevention, but we haven't always been really focused on opiate misuse and abuse. And so we've really tried to increase the awareness about the adverse effects of opiate use among youth. And it's really been a success. There's actually been, the Spring Youth Forum has been completed. There were 664 registrants. They had very high ratings for their presentation, and 92% of them said they'd recommend this conference to others. So we really feel like we're being more focused on opiate use, misuse, and prevention now that we have this grant, and this is one example of that. Prevention project number 6 is Community Prevention and Wellness Initiative, CPWI. This is really an expansion of a program that we've had in the state for quite a while, but it allowed us to expand our CPWI to 5 additional high needs communities. So we really went out and did some strategic planning and some focus, and really looking at where are those communities, and then how can we really help them raise awareness in the community about opiate misuse and abuse. The 5 contractors for the STAR CPWI expansion are Pacific County, Cape Flattery School District, Skagit, Whatcom, and Spokane Tribal Network. So we really felt like after we developed where those high needs areas were, they sent out a prospectus and had organizations apply to help do this expansion. This is I believe it's up to almost, I think, 60 CPWI sites around the state, and a highly successful program. Prevention project number 7 was analysis of evidence-based practices. One of the things we began to recognize as we looked at this grant was that we really need to understand a little bit more about what are the evidence-based practices for teaching youth about the issues related to misuse and abuse of prescription drugs. And so we contracted with Washington State University to conduct an analysis that says, okay, here are all these different kinds of projects, because we know that sometimes prevention projects, while intended, do not really produce the results that we want to get. So we were very, very intentional about what kind of projects and what kind of practices would we be using. The status is that they've developed these. We've pushed them out to the CPWI sites. They have a list of those projects, and they understand that, and they are using it. So this is an ongoing project. We'll continue to look at how do we really focus in on what works in prevention. How do we really get at the issue about opioid misuse and abuse, and the project will be ongoing. And finally, prevention project number 8, which is community enhancement grants. This was all about promoting safe storage and appropriate disposal of pain medication to prevent misuse. Again, we know that 75% of people who misuse and abuse opioids generally obtain them from other sources, whether that be friends, family, whether they're given or taken. We know that safe storage is a component of prevention, and so we really wanted to focus on that. So we're funding 10 to 15 communities around Washington State for evidence-based take-back programs. We're trying to reduce prescription medication, opiate misuse and abuse, and it's really been an important component of what we're doing. Right now we have contracts with 4 CBOs that service 39 communities. The action plans have been developed, and they're also working on evidence-based programs such as Strengthening Families and the Good Behavior Game. So from the evaluation that Washington State University has, one of the best practices that we've been able to identify are the Strengthening Families and the Good Behavior Game. So really what we're doing is sort of utilize the information we learned from one element of this grant and using it for this element of the grant. Excuse me. Oops. So we're going to talk now about the prevention project that we have, and there's 10 prevention projects that we have going currently. So 8 of them are prevention, 10 of them are treatment. And these are the overview of those 10 projects. Again, we'll go through the same sort of thing. So the first project is called Hub and Spoke. And so we have approximately $9 million that we're spending per year on these projects. And almost $5 million went to expanding medication-assisted treatment. So really what we did was we went out and said, we need to develop a hub, a place where people can be provided medication-assisted treatment. And then we need to have spokes out to various kinds of organizations that are treating these individuals. And what we really wanted to look at was that there's no wrong door. You know, that no matter where you enter the system, if you're interested in utilizing medication-assisted treatment, that that they can get you to a hub. They can get you to a place where we can provide at least 2 of the 3 federal FDA-approved medications. And so we really went out and sort of researched it and tried to figure out how does it work best. And there are a few different models that Hub and Spoke are associated. One is called the Vermont model, but we really needed to get this set up in about 4 months, actually just 4 months. And so we had a lot to do in order to get this moving. Here is the status of that. We currently have Cascade Medical Advantage, and you'll see the counties that it serves below. We have Northwest Integrated Health, Peninsula Community Health, Valley Cities, which is King County, Harbor View Medical, which is King County, and then Lifelines, which is Clarks, Kamenia, Grays Harbor, Pacific. All of these projects began by 8/31/17. So you imagine that we were notified of the grant May 1, and by 8/31 we had to have a project up and going. It was quite a bit of work, but a lot of interesting information from that. This is the location of the hubs and spokes, and I don't think you can really one of the things you recognize right away is that all of the hubs are currently on the west side. And that is having to do both with not a lot of development yet on the east side for medication-assisted treatment. There is also some political and more conservative abstinence-based orientation on the east side. We are certainly looking at how do we expand into Eastern Washington, but at this point we have all of them on the west side, and we'll talk about that a little bit later. But we did have, I think, 2 applications from the east side, but we just felt like getting it up and going in 4 months was probably the most important thing we can do, and the viability on the west side having to do with population and location, it seemed to be more appropriate at this point. Treatment project number 2 is mobile OTP vans. Evergreen Treatment Services and King County was interested in purchasing and deploying a mobile van for opioid treatment. So this would be methadone. And one of the things we knew was that they already have an existing license for a mobile van, and because OTP, opioid treatment programs, are operated under a multitude of different organizations, and the DEA is one of those involved, we knew that we had to get at least it up and going, and that we knew Evergreen already had a license for a mobile van, and so we were able to sort of get that moving with them. And one of the reasons why I'm sort of struggling with this one is that the van that we're currently replacing for Evergreen Treatment Center, while it isn't a van, it is not exactly mobile, and so they've really we've really struggled to get them up and going. They're doing a great job, but it's not exactly what you'd imagine in terms of the type of vehicle you'd want to use for this. Also, the DEA is currently in a revision process of rulemaking for mobile clinics, and that process has been stymied us in terms of developing other programs. Each of these vans cost about $200,000. Initially, we had enough money in the grant to provide 2 vans, but because the licensure has not been okayed, we've not been able to do that. Another significant issue with the mobile vans is that there's about an 8-month lag between the ordering and the delivery of the van. So while Evergreen is doing a great job, they are still working out of their old mobile but immobile van. So this is something that happens on the treatment side projects, and not as much on the prevention side, but research data analysis does a dashboard for each of us. So you can see that they are exceeding their target by a significant amount, and we're really pleased with what they're doing. So it lays out demographics, gender, age distribution, and then, as you can tell, because it's an OTP, it's almost 100%, or it is 100%. It is 100% methadone. Is a mobile van? I'm sorry, I missed the chat, but we'll get to your questions in the end. The reason we'll get to the van later. We'll talk about that one as we move through this. So the second project is, the third project is low barrier buprenorphine pilot, and it's basically working to provide buprenorphine to people who otherwise are unable to be induced and stabilized. So we're talking about homeless environments, folks that may be circling through systems and simply do not have enough services surrounding them that they're able to access care on on a regular basis. And so this is really all about getting people from one kind of service into buprenorphine quickly, so Suboxone, and then basically trying to dose them on a flexible dosing scale over 30 to 60 days. And it's really all about providing need where it's most needed and at the place where it's most important. So we've worked with the University of Washington Alcohol and Drug Abuse Institute, ADAI, and they're working with Seattle Unit Health Board to develop this program. The contract is completed, and again, it's been really a highly successful program, as you can tell from this dashboard. So, you know, we expected them to have about 44 people in the program. They are currently at 86 unduplicated patients. So they're really going gangbusters from the very start. They took off, and it's really exciting to see, because this is a population that is difficult to serve. And as you can tell, they're really, they're doing a really good job. You can see the demographics and the ethnic breakdown of that. So project number 4 is called the Pathfinder Peer Project. As I mentioned earlier, substance use disorder peers are not part of the Washington state plan. So this is really giving us an impetus to build a SUD, substance use disorder peer project, that we can replicate statewide. And so these folks are working with an already established DBHR project to provide basically outreach in really 2 different environments: emergency rooms and homeless encampments. And they're linking individuals to MAT services, to the hub and spokes, to the low barrier environments, and really helping them navigate and address those barriers necessary for independence and recovery. And that's $1.66 million a year. So because we connected it to the PATH project, we have this available in all sites around Washington state. So each of the behavioral health organizations or the managed care organizations have these teams in place, and they're going out and they're doing that. And they're also working on establishing it in the emergency rooms, which has been a bit more of a challenge for this project, because oftentimes the ERs are looking for credentialing, and oftentimes peers don't meet those credentialing requirements. So that is a work in progress, but it is happening. So project number 5 is tribal treatment, and we really were interested in encouraging tribal environments. Tribal environments have really come a long way in terms of looking at utilizing medication-assisted treatment in their communities. We really have some great organizations, great tribal communities that are doing that. We also have tribal communities that are still struggling with a basic absence-based project, absence-based only orientation, but is really coming along. So we're helping support tribal conferences. There's 2 coming up, one in North Sound and one in Spokane in June. And we're really creating funding also for another element of the media campaign, is to build awareness related to medication-assisted treatment for Native American communities, so for tribal communities. So it's an ongoing development. It's part of that prevention project number 3, and it's really working with the folks to get those conferences and those presentations out. And we're really excited that we're on board. We are actively working that project. Project number 6 is treatment payment assistance. We provided almost $250,000 to the 10 regional service areas to offset treatment costs. It's, again, intended to offset deductibles, co-pays for clients. It's really all about if a patient seeks services and there's no money to pay, how do we pay for it? And that connects to goal 2 of our state strategic plan. We have contracts in place with the behavioral health organizations or ASOs, and some of the BHOs are contracting with specific treatment providers. So, and in case of Pierce Optum, they are working with Northwest Integrated Health, saying, if we have a person who doesn't have insurance or coverage, we'll send them to you, you bill us, and we'll pay you. So it's really been a nice development on their part of creating those networks and making sure people get services. Project number 7 is the opioid use disorder treatment decision and reentry. It's basically working with the DOC programs. DOC worked with us from the very beginning to kind of create their own ideas about what would work. And so this is really 2 different programs. The first program is a reentry work release and violators program. It's located in 5 communities across Washington State, and it provides reentry for people who have been violated or on work release. And it really identifies who's got an opioid use disorder, and then can we connect them to access. So first, can we identify them, and then can we get them into services either at a hub and spoke or a low barrier BUP or some kind of OTP project. The second one is called the CORE program, and it's Care for Offenders Released from Prison. So this is when a person is released from a prison, they are connected with a MAT service provider in their county if they're interested in. And in both of the projects, they're to receive naloxone upon release from incarceration. We know that one of the highest risk areas, highest risk for overdose, are newly released individuals, either from jails or prisons. And so we've really been impressed with the work they've been doing. It's been a tough project to get off going, but they're working on that. And so, so far, one of the other ideas that we did is we connected with the ADAI, Caleb Bentham Green. He has had another project that he had going, so he's working with the CORE program. And we've also been doing quite a bit of training with the 13 correctional facilities, so the classification staff. So we've really made great inroads and great connections to DOC, and I have some great partners over there. These are the sites for the reentry services, Nisqually, Kent, Yakima, South King County. So it's really been a broad base of and both east and west. Just to kind of show you a little bit about what's happening. This is for the treatment decision model. So this is all the work release. We have almost or 1,000, excuse me, total screens. And so what they're doing is they're actually reaching out and they're trying to sort of identify who needs these services. And while it may seem to be an easy project to implement, there is also a cultural or a culture barrier about, is medication-assisted treatment just replacing one drug with another? Why should you have a person being dependent on medication? So we've really been kind of working through those issues, some of it having to do with the training we're doing at the correctional facilities. This is the number for the CORE project. Again, it's a little bit behind target, but it's coming along, and we're actually meeting in a few weeks with the DOC folks, and we're going to try and develop additional sites so that they can get their numbers and hit the target. So again, I didn't want you to think that every one of these projects is exactly right on the money and going, so I included this one as an area where we have some work to do, but it's good work. And treatment project number 8 is the Bridges to Recovery. This is a juvenile element where we're actually working with JR on a evidence-based project called ACCRA. And it really is all about increasing education, youth employment, and really addressing systemic barriers to folks, young adolescents who are involved in the juvenile justice system. And it has been also one of those areas where we've really had to make some pretty tough inroads because for a couple of reasons. One, medication-assisted treatment for adolescents is not a very popular thing with providers. So providers have struggled a little bit with how to do it. And then how do you connect youth into the community upon release? How do you connect them to services has been a challenge for us. Actually, Harborview Pediatric is just coming on board with their interest and availability of medication-assisted treatment for adolescents. So we're getting there. Treatment project number 9 is Naloxone Distribution. The funding provides partnership with ADAI, and what we're looking at is where are the underserved populations for naloxone. Naloxone is the anti-overdose, or the short-acting naloxone, which basically reduces overdose risks. This is an area where the state has actually had quite a bit of experience. We started Naloxone Distribution 3 or 4 years ago working with ADAI. And we also have another grant called the Preventing Deaths from Opiates, the PDO grant, which is doing about $1 million dollars a year. Excuse me. So it is really a quite involved process of doing. We certainly can send out a post of all these slides. So prescription monitoring is project number 10. And so we connected this to goal number 4, which is using data information to detect opioid misuse and abuse. We help support the Department of Health's DOH in prescription monitoring program. So when a provider is going to be prescribing opiates to a person, what they'll look at is the prescription monitoring program. And what we really want to do is improve the functionality of that prescriber. So we're also doing a summarizing of prescriber patterns. So it's not really a report card, but it's like how is my prescribing practices compared to other people in my same discipline. And then we also use the PMP data to develop prevention data books for CPWI, so the prevention side of this. So we really tried to sort of integrate both prevention and treatment and good monitoring for physicians. So physicians can do good monitoring of these projects throughout the state. So this project is in place. They hired a compliance specialist and epidemiologist. They created the feedback reports for prevention, and then the prescriber feedback reports are due this week. So we're pretty excited that those projects are on task and in place. So again, this is the 10 different projects, about $9 million. It is both with the prevention and the treatment projects. It's about 52 state contracts to different providers around the state. So it requires a host of groups that are involved in the project and doing their work. And so it is good. That is my contact information. You can contact me. I saw there was one chat question, which was, will these slides be available? Absolutely. We can make those available through ATTC. And then the second piece is that Stephanie Endler is actually the project director. She started in July, and she's actually the project director for STAR. So if you have any specific questions about STAR, you can certainly copy her and copy me, and we can get back to you. I think that's it. Are there questions?
Yes, so thanks so much, Tom. So we are going to start with the question time. Oh my God, this is not what I meant.
That's fine. Thank you.
Okay. Okay. So how do we, can I move to the next slide?
Yeah, you can just go ahead and click here.
Next. Okay. Thank you so much. So first of all, before we go to questions, just to remind you that you will get, you participants will get 2 surveys about this webinar today. One now and then another one in a month. The second one, you're gonna get a $5 gift certificate if you were to respond and help us assess our activities. Thanks so much, Tom, first of all.
No problem.
And I would, as you said, yes, all the information will be available to our website. We'll get them very soon, and you're going to get an email about it. In terms of questions, so we have some questions, as already was mentioned, about availability will be available to our website. Other questions is so it looks like, so one says, hi there, thank you so much for this update. I understand that year 2 is funded. Do you have updates about years 3 to 5 funds?
I wish I did. We absolutely do have year 2 funding. Again, we're because this is a large project, 18 different projects, 52 contracts. We have to wait until the federal government gives us the notice of award, which we're expecting in mid-April. So right now we're getting ready to push out year 2. We're hopeful that year 3s, 4s, and 5 continues to happen, but it's anybody's guess. We aren't getting any clues right now from the feds of whether or not we're going to have years 3 through 5. But I fully expect, and I know that we will work to respond to the need that's happening out here. So we really are interested in, one of the things that was included in the budget this year was dollars for additional funding for the hub and spoke. So there is money in the budget for 4 more sites to be offered. And we're really going to try and get at least 2 of those into Eastern Washington. So we're excited about that work.
So I think that already responds a second questions related to what you just said. Is any word yet on the hub and spoke expansion if it's passing the state budget? So it might be related.
Yep, absolutely. We're on it. It's going to be happening. We're going to want to get it going by July 1st. So we're having meetings this week that's going to talk about, we'll be sending out an RFI, request for information, and ask you kind of what your project looks like, and then from that we'll choose. Again, we're committed to choosing at least 2 sites in Eastern Washington this time, as we know the need is there. So yeah, it's going to move ahead. There's also money for naloxone in the state budget for tribal communities, so we'll be working on that project too.
Thanks, Tom. So another question is, how did you decide to limit your hub and spoke project to 5 spokes and hub per hub?
We actually, it was just basically about how much money did we have, how much money did we think it would take in order for these organizations to do a good job of getting it up and going. Again, to have from conception to accepting the first person in your program, 4 months is a pretty tight window. So we really just basically thought, well, what do we think it would take to hire a nurse, to hire a nurse care manager, hire a hub manager, hire spoke navigators to really make the project work. And one of the things I forgot to mention was that the spokes could even be just referral only. So jails, syringe exchange programs that aren't providing services per se could still do referrals into the hub. So we've really been able to, in many ways, make these organizations or encourage these organizations to create their own hub to fit their community rather than having the state say, this is exactly what it has to look like. And I think that's been really a good selling point for this hub and spoke model.
Very good, thanks. There are another question. There are 3 more questions. I think that's all we're going to be able to cover. Can you give more information about the PMP data and reports?
Actually, I helped make sure that the money got to them. I would encourage you to contact me, and I will connect you up with the Department of Health. Chris Baumgartner is probably the best person, but simply let me know. I will connect you to the right folks over at the Department of Health. They really probably know more about it than I do.
Okay, thank you. The 2 last questions. Can you help explain more about why there are no abstinence-based programs? Lack of data, perhaps?
Yeah, that's a really good question. This grant was really focused on increasing medication-assisted treatment. And abstinence-based programs work for millions of people, me included. But it's just part of the continuum. And one of the things we've learned over time is that people with significant adverse childhood experiences, trauma, those sorts of things may not respond as well to abstinence-based programs or 12-step models or going to meetings. And having been a former provider, I remember saying, well, don't use and go to meetings. But for a person who has a significant trauma history or a mental health issue, that isn't the right answer. There may be another answer. So this was really all about moving medication-assisted treatment into the realm of the continuum. And in terms of the hub and spoke, we've asked them to use both a antagonist, so Vivitrol, naltrexone, which is an injectable, Arivia, which blocks opiates. So that is very much can be used with abstinence-based, and then also use at least one agonist or partial agonist, either methadone or Suboxone. And because we have all sorts of different varieties of hub and spokes, some of them are OTP centers, so they only do methadone. Some are OTP centers that do methadone and buprenorphine and Vivitrol. Some are FQHCs, federally qualified healthcare centers, and they do buprenorphine and Vivitrol. So it's really been a nice coming together. And again, I think that we recognize that not one treatment works for any one person, and we have to have the full continuum available.
Okay, thanks again, and let's get to our last question. Does the overall project involve recruiting or waiving additional medical professionals to provide buprenorphine?
Currently, it does not. Although we just received information from the AAAP. They received a grant from SAMHSA to help provide TA for recruitment of additional waivered physicians. And what it appears is that the most successful hub and spokes are actually out there developing the network of other waived physicians to do this service. So we recognize the interest, and we also recognize the advantage of developing that model, and also recognizing that most of the physicians and PAs who are waived are serving 5 or less patients. And so how do you really increase access to those sorts of services? One of the ways that it's happening is that the state legislature gave us approximately $1 million a year to provide nurse care managers in some of the OBOT environments. And so there's really kind of a multi-prong approach to encouraging additional WAVE physicians to come on, to take on more patients. But we do know that this can be a very complicated population to serve, and that what we really need to do is to help them get out of the day-to-day management and into the idea of prescribing, and to have someone else do that. And we also, in this last legislative process, have increased the reimbursement rate in Medicaid for medication-assisted treatment. So we're sort of got a couple different projects going on that level, but we're working on it.
Okay, well, thank you so much again, Tom Fuchs, for participating in our webinar. It's really important information here. And thanks for all the participants of navigating with grace our little glitches. And we hope to see you in the next webinar. It will be also about opioid with Dr. Joe Merrill on management of opioid use disorder in primary care. Thanks so much, everybody. Bye, Tom.
Thank you.